Hi, my name is Christopher Hudgens. I'm a medical liaison with Solventum. This video is intended for healthcare professionals. Temperature is an important vital sign that helps you provide safe patient care. The importance of human body temperature have been known since antiquity. However, the first practical clinical thermometers, which were made of mercury, did not become commercially available and widely used until 1867. A lot has changed since then. Today, you have a variety of thermometers to choose from in the perioperative setting. However, they're not all the same. Some are less invasive and used more frequently in pre- and post-op. Others are more invasive and used in the operating room when patients are under anesthesia. Some measure core temperature, while others predict or estimate core temperature based on other measurable variables. Some measure temperature of the core, others near core, and others the skin. Lastly, all thermometers used in the perioperative setting do not have the same accuracy. Accuracy of a clinical thermometer is generally defined as a combined inaccuracy of a site or thermometer not exceeding plus or minus 0.5 degrees Celsius from true core. Now that we've looked at some differences in thermometers, let's look at some frequently used thermometers in the operating room. Pulmonary artery catheters are the best estimate of core temperature. They are considered to be the gold standard for temperature monitoring. They must be inserted into large veins and threaded through the right ventricle into the pulmonary artery. Invasiveness is high. They carry many risks, including infection and puncture of vessels. Therefore, they are normally only used when hemodynamic monitoring is required for critically ill patients or during high-risk procedures. Esophageal probes have good accuracy. They must be placed behind the heart and distal to the area of maximal heart sounds. In adults, 12 to 16 centimeters, or they could be affected by respiratory gases. Invasiveness is medium. They carry the risk of local irritation and, although rare, perforation of the esophagus. Nasopharyngeal probes have good accuracy. They must have good contact with mucosa and in adults should be inserted past the nares 10 to 20 centimeters. Inserted too shallow, they could be cooled by environmental temperatures. Inserted too deep, they could be cooled by respiratory gases. Invasiveness is medium. They carry the risk of local irritation and bleeding. Tympanic membrane probes. The types that contact the tympanic membrane have good accuracy. They must be in direct contact with the tympanic membrane and are often not inserted far enough due to the bend in the ear canal. Invasiveness is medium. They carry the risk of local irritation and perforation of the tympanic membrane. Foley catheters with temperature sensors have good accuracy. They are not accurate with low urine flow, frequently seen with pre-procedural intake restrictions or limited intravenous fluid administration. They lag with rapid temperature changes seen during cooling or warming for cardiopulmonary bypass. They can also be influenced by operating room temperature during lower abdominal surgeries. Invasiveness is high. They carry the risk of infection. Rectal probes have medium accuracy. They should not be used when loose stools are present, and in adults, they should be placed past the sphincter 8 to 15 centimeters. They lag with rapid temperature changes seen during cooling and warming for cardiopulmonary bypass. They can also be influenced by operating room temperature during lower abdominal surgery. Invasiveness is medium. They carry the risk of local irritation, rectal perforation, and can be dislodged during movement or positioning. Liquid crystal temperature strips have low accuracy. They are highly influenced by ambient temperature and could be influenced by forced air warming devices. Invasiveness is low. However, they carry the risk of incorrect measurement, which could result in delayed or inappropriate treatment. Next, let's look at those thermometers frequently used in pre- and post-op. Oral thermometers have medium accuracy. They should be placed in the sublingual pocket under the tongue. They can be influenced by the intake of food or water, head temperature, and breathing rates. Invasiveness is low. Axillary thermometers have low accuracy. They require probe placement over the axillary artery with the arm positioned at the side. Invasiveness is low. However, they carry the risk of incorrect measurement, which could result in delayed or inappropriate treatment. Tympanic thermometers, The non-contact infrared type have low accuracy. They are usually too large to be inserted past the bend in the ear canal so the infrared beam can see the tympanic membrane. The presence of earwax can interfere with measurement. Invasiveness is low, however, they carry the risk of incorrect measurement, which could result in delayed or inappropriate treatment. Temporal artery thermometers, sometimes called scanners, have low accuracy. They measure skin temperature on the forehead. The manufacturer may recommend cleaning the lens after each patient and adjustments to current facility fever protocols. Invasiveness is low, however, they carry the risk of incorrect measurement, which could result in delayed or inappropriate treatment. Finally, let's look at thermometers that can be used in each phase of patient care. Zero heat flux thermometers have good accuracy. They correlate closely with more invasive core modalities, including pulmonary artery catheters, the gold standard. They can take a couple of minutes during startup. Once equilibration occurs, they continuously measure core temperature. A single sensor is placed on the forehead before surgery and is worn throughout the perioperative journey. The sensor stays on the forehead and is disconnected from the sensor cable and reconnected at each point of care. This provides a standardization with one system that helps improve consistency, reduce the opportunity for error, and eliminate the duplication of effort required to purchase and store multiple products. Invasiveness is low. They can be used on non-anesthetized and anesthetized adult and pediatric patients in the perioperative setting, emergency department, intensive care unit, and any other department in the healthcare setting where temperature monitoring is required. In summary, you have a variety of clinical thermometers to choose from in the perioperative setting. However, it's important to know that accuracy varies as well as invasiveness and associated risk. If you have any questions or would like more information on temperature monitoring, please contact your local clinical or salesperson at Solventum.